So I is for inspection, and what we're going to do is inspect all areas of the patient's body. And if we weren't able to do this, one, we were taking off the clothes. It's because we cut them off with the trauma shears and just laid them open, but didn't actually pull them out from under the patient. We're going to inspect all areas of their skin and body for other injuries. So to review, A is for airway, make sure the airway is clear. B for breathing. C for circulation. D for disability. How much disability does the patient have? E for environmental and expose. We're going to expose their skin, and we're going to keep the environment as warm as possible. We're going to be keeping the patient as covered as possible and as warm as possible. F is for frequent vital signs. G, give comfort. H is going to be when we do the head to toe assessment in history, and I is for inspection. So lots happening at the same time. The ER tech will be working alongside multiple RNs. Sometimes there can be 3 RNs, one doing the neuro assessment, one taking care of the left side of the body, one taking care of the right side of the body. So multiple IVs being inserted. Sometimes the ER doc is intubating the patient. If the patient's already intubated, then the respiratory therapist may be bagging the patient or putting the patient on the ventilator. Sometimes the RT needs to leave to get a ventilator, so nursing or the ER tech can take over the bagging and the time it takes to get the ventilator and then get the patient on the ventilator. So doctors may be putting in central lines, chest tubes. So a lot of things happening at the same time, and we need to get this all done in a very orderly manner and cover all steps of it so that the patient can get to radiology for CTs of the brain, abdomen, pelvis, face, um, depending on their injuries. And based on the results of those CT scans, the decision made whether the patient needs to go to surgery right away or whether they should be stabilized and treated medically and gone to surgery later. In the case of a patient with a broken leg, um, unless it is sticking, the bone is sticking out of the skin, they're going to wait until the patient's more stable to take it. If they have a crush injury to the chest, they may need to deal with it now, or internal bleeding in the abdomen or pelvis. So the ER tech's role can vary depending on what exactly needs to be done, from taking vital signs, running blood, maybe getting more IV fluids from the storeroom, getting chest tube kits, just depending on what the trauma involves. Now, the local hospitals are not going to see trauma like um, in Harborview, so trauma is defined differently in all facilities. Having just a motor vehicle accident can be traumatic, yes, but chances are, if it's a serious accident, the patient is going to be taken to the trauma unit at Harborview. So how much trauma you'll see if you work at, a local hospital is questionable. Now, I know that you are all concerned about seeing that kind of incident, and certainly it would be scary, but you will have lots of coaching and lots of help, and you're not going to be left alone by any means. There'll be plenty of people there. You're not going to be alone with the trauma patient. Even when it comes time to transport a trauma patient to another department like CAT scan, you're going to have a respiratory therapist with you if the patient's intubated to bag them. You're going to have an RN or two with you and possibly another ER tech. So don't be scared. it is, there's a lot going on. And what I've found over the years is the time that people get most upset at is after these things occur. And whether it's a code blue or a trauma, the while it's happening, we're just in a function mode and get through the moment and deal with it. But it's after the fact when you sit down to have that cup of coffee and you go to chart, or you sit down and talk to your coworker, that you start questioning yourself and say, oh my gosh, I should have done this, or why didn't I do this, or my compressions weren't strong enough, or I couldn't find the IV fluid that they wanted, or, I was opening and closing the uh, crash cart drawers because I couldn't find this and I should have known where it was. And questioning ourselves will always happen after an event. It's part of the process. But in a serious incident, the hospital has debriefing sessions where the staff will actually sit around and talk about it and what could have gone better. And everybody kind of vents their feelings. And you can do this one on one with one of your coworkers or a trusted RN. And, we all do the best we can in these situations. And, you know, if you're not used to doing this, it's difficult. If you work at Harborview and you're doing it 4 or 5 times a night, maybe more, it's second nature. So, what I can advise you to do is, learn what you're supposed to do, learn the A through I, so that you know what's coming next. You can anticipate it. You know that you have to do frequent vital signs. You know you have to do an EKG. Um, Obviously, if the patient has a huge chest wound, and you might have to adjust where the leads go temporarily, because you can't put leads over a huge open area. But all these things will happen and you will learn how to do them. Now, I did notice in your textbook under the role of the ER tech on page 46 that it says that insert urinary catheter. Now, this book is written for ER techs across the country. In Washington State, ER techs do not insert Foley catheters or urinary catheters. It is a RN job. The ER techs do not insert anything except needles to um, aspirate blood, but for a peripheral stick. All others is the function of the RN.